Heathrow Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We are Asia's largest API manufacturing. We have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare, a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. We are pioneering quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, introduced Oseltamivir, Favipiravir, and Remdesivir, for which they received an award in August 2020, award for COVID drugs from Pharma Excellence. Today's webinar, role of Oseltamivir in flu management. We have speakers. We have moderator Dr. Pramod Jog with us, and speakers Dr. Anil and Dr. Somashekar. Welcome, doctors. Welcome to this program.
Thank you, sir.
Dr. Pramod Jog, sir, we know is Professor of Pediatrics, DY Medical College, Pune, President IIP 2016, Steering Committee member GAVI CSO 2016 to 2019, Chairman Mini Recipe Module IIP, author of book Cophology. Welcome, sir. Professor Dr. Somashekar is Professor of Ramaya Medical College, Pediatric Pulmonologist and Adolescent Care Specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore, Secretary AHA 2016-17, EB Central IIP Respiratory Chapter, EB Central IIP 2015-2016, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Executive Editor, Journal of Pediatric Pulmonology, EB National Respiratory Chapter 2023, Secretary Environmental Chapter of Child Health Group IIP 2023-24, President IIP Bengaluru 2024. Welcome, Dr. Somashekar. Dr. Anil MU is MBBS MD Pediatrics with Fellowship in Pediatric Critical Care, DAA Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatric and Pediatric Critical Care, Sparsh Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I hand out the session to Dr. Pramod Jog. Over to you, sir. I'll stop sharing.
Thank you. I will just share my screen so that we can start. Yeah.
Yes, sir.
I hope the slides are seen.
Not yet, sir.
One minute.
Yes. Now this is now we can
see. Okay. Are they in the full screen mode? Yeah, I hope so.
Yes.
Yeah.
Yes.
Thank you. Okay. Very good. So good afternoon, all friends, all the viewers, and we will be discussing a very interesting topic today, and that is related to the use of Oseltamivir in flu management. We all know that the monsoon in most of the parts of our country is in full swing, and we are facing so many viruses, influenza being one of them. In addition, we have RSV, and though not respiratory, but we have dengue virus also to some extent in different parts. And we have two influencers, Dr. Somashekar and Dr. Anil, who will be discussing influenza with us. And if you see, I was the president of IAP. So I always call that, every year there are different strains in IAP. So I was the 2016 strain, okay? And I put my name in the fashion of the influenza virus, which gives you the origin of the virus, the month and the year of isolation, and the place from where it was isolated. So with that, I always like to tell my colleagues that there are some entities, which are always very happy when monsoon begins. And of course, farmers are the first ones, followed by the frogs who are in hibernation for a long time. And of course, the doctors, because the season is in full swing, and the pharma, because again, the sale of the medicines is in full swing. Okay. But now, whenever a child comes to me and I feel that it is viral, earlier I used to be relaxed that, the onset is with cough, cold, there is involvement of different systems and nothing to worry about. It's a self-limiting disease. But now these viruses, are creating a problem. And particularly the RNA viruses, they are very naughty viruses. RNA viruses are, of course, the influenza, the COVID and RSV, all these, they are known to change their structure very, very frequently. And of course, that's one of the reasons why we have to give influenza vaccine of a different strain every year. With all said and done, it is important that we try to find out as to what is the problem with that child, what is the probable diagnosis in that child. And we have witnessed so many viral infections following COVID, and there have been waves of different viruses. I remember in 2022, the latter half, when the COVID pandemic was on decline, at that time, different viruses like RSV, then measles virus in some places where vaccination was on the lower end, and then hand foot mouth disease and adenoviruses. So in different parts we had different epidemics also. And the reason was that during COVID, all children were indoor, and they were not exposed to those viruses, and they never developed any antibodies against those viruses. So these waves came up, and even the older children, they were affected. And the story continues. And that's why we are facing children with recurrent respiratory infections, otitis media, adenoidal hypertrophy, influenza, which is surging up not only in monsoon but in other seasons also. And this adenovirus, which I just mentioned, has become a bad adenovirus. Okay, and there are diagnostic dilemmas because viral infections like adenovirus are producing high counts and high CRP, and there are therapeutic dilemmas where we start with amoxicillin, and then the throat swab shows positivity for H1N1, and then we are in two minds whether we should continue with antibiotics or with only the antivirals and so on and so forth. So here is a 3-year-old boy who came for fever, cough, cold, and progressive breathlessness for 3 days with tachypnea and hypoxia, and X-ray picture showing ARDS. A child got admitted to the PICU, got ventilated, and received oseltamivir and supportive therapy. And H3N2 came positive from the throat swab. He was ventilated for 3 days, and then he improved. Okay. Now here the question was whether this oseltamivir could have been started early, because a previously healthy child coming with cough, cold, and fever progressing over 3 days, whether the treating physician would have prevented this particular progression. And the question is whether every patient of cough, cold, and fever be given oseltamivir upfront, particularly in the flu season. And there are some points of confusion, because these are points of confusion related to flu. So whether this infection is bacterial or viral, if it is viral, which is the virus, whether it is rhinovirus, adenovirus, influenza, parainfluenza, RSV. If it is influenza, whether this is H1N1 or H3N2, and then whether I should start oseltamivir upfront so that I play safe. So there are many questions for which we are trying to find out answers, and we all are aware that in monsoon we have H1N1, so many influenza-like illnesses, and also severe acute respiratory illnesses, and we had witnessed COVID-19 over 2 to 2.5 years. And then if you have a look at flu in India, the incidence of influenza and the related deaths has been increasing alarmingly over past few years. And we all are aware that influenza is of three types. The virus influenza A, which produces frequent epidemics due to minor antigenic variations. As I told you, it's an RNA virus, and every year we have some change in the composition of the vaccine, and this is notorious to produce periodic pandemics. And influenza B, which infects only humans and produces local epidemics. And we have witnessed four major global pandemics with flu: 1919, 1957, 1968, and 2009, which many of us have witnessed. So with that, Dr. Anil, I have a quick question for you as to whether there are any recent updates about the epidemiology and the circulating strains of influenza viruses affecting pediatric populations in India. Because, in Pune, we have this H3N2
Yes, sir.
circulating to great extent. So what is your opinion?
Yes, sir. Even here in Bangalore and across Karnataka, we are getting a major epidemic of H3N2 itself. And
Okay.
rarely, yes, H1N1 is being detected. But we should note that the H2 series is not being detected anymore. So it is gone out of circulation. So I think we should not be worried about the H2 series at all. So currently, we are having an epidemic of H1N1 and H3N2. And these influenza B lineages also are not seen, sir. Not seen anymore.
Okay. Because as I'm sure you are aware that now WHO, in the composition of the flu vaccine is going to remove that B type, and it's going to bring only the trivalent influenza vaccine.
Yes.
Though there are differences of opinion about it, but as you say, this type B, I can understand it's not seen to a great extent in Bangalore, isn't it? Yeah.
Yamagata, Victoria, we are not seeing it anywhere. So that's
Ah.
why they're trying to remove that and proceed with the trivalent vaccine.
Oh, okay. That's good that you told us. And then, of course, we all know that this flu can spread from one person to other up to about 6 feet. And these viruses, they spread mainly by the droplets, while a person coughs or sneezes or talks. And the droplets can land in the mouth or the nose of the people who are nearby. And that's why we always say that we have to stay away from the affected person. And we all know that there are some glycoproteins on the outer side of the influenza virus, which are labeled as HA and NA. And HA, hemagglutinin, is the one which attaches to the respiratory epithelial cell so that the virus enters and the RNA enters into the respiratory epithelial cell, and it starts multiplying, produces different virions, and then these virions are ready to get out of the respiratory epithelial cell and infect the other cells in the vicinity. But this neuraminidase is the one, the glycoprotein of the virus, which usually acts as a molecular seizures. So all those virions which are which have gathered at the exit, they are like a Caesar, they are cut, and then these viruses, virions, are sent outside. And the molecule that we are going to discuss today, oseltamivir, acts exactly at this point, so that this particular exit of influenza virions is stopped, and that's why the further spread of the disease is halted. With that, Dr. Somashekar, in your experience, what are the different clinical presentations with which influenza virus presents in pediatric population? And when do you suspect influenza infection, particularly when children with respiratory symptoms come to your OPD?
This is the season is there almost like it's a pandemic that whatever the epidemicity is there, majority they present with fever, cough, cold. Little, if you take flu-like illness, headache, sometimes they'll have vomiting, diarrhea. That's a different story. But if you take RSV virus, adenovirus also behave like this only, more or less same. But only thing is RSV, if you take like bronchiolitis, picture is more. And if you take adeno, it is a general syndrome like a conjunctivitis, coryza, or things are more. But here, common symptoms are same. But when it comes to H1N1 or the influenza, you should suspect after 3 days or 4 days, the symptoms are not reduced. If it is progressing to the generalized tiredness, progressive respiratory symptom, that is the time you have a strong suspect. Otherwise, majority behave like that. Maybe high index suspicion can be given to other viruses like RSV or the adenovirus or the parainfluenza virus. It may mimic like a croup-like syndrome.
Yeah, I agree. And I will just like to add that, these children with influenza-like illnesses, so many are there. But I always say that influenza is the father of all those influenza-like illnesses, because it comes with headache, myalgia, muscle pain, and older children, many times, they are lifted by the parents, because of weakness. These children, they don't walk. And as you rightly said, RSV along with influenza is also seen. Though RSV affects mainly children under the age of 2, influenza can affect even the older age. And some of my colleagues have seen influenza presenting with febrile seizures. Okay.
Yes.
And and some of my friends also saw some children with encephalopathy.
We had
And
a patient. I think
yeah,
Anila has experienced more being an
uh,
intensivist, and we had a patient
We
that
had
presented
patient
like a
presenting with
meningitis.
necrotizing encephalitis also, with the
oh,
bilateral thalamus being involved. What a typical JE kind of a picture that we remember from our books. We had
okay.
a similar presentation, child coming with acute febrile respiratory illness, became drowsy, had continuous seizures, and then progressed on to became comatose. And on evaluation, it turned out to be acute necrotizing encephalopathy.
Yeah, that's
We
something
had
which
one
is.
more comorbid, like nephrotic syndrome, recently detected. Once developed respiratory symptoms, progressed to shock, ventilated, ARDS, of course, detected, recovered fast.
Oh, I see. Okay. Now, Dr. Anil, many
Yes, sir.
times, when we discuss in our meetings, we always say that, viral infection means, multi-system involvement. In the same child, you get fever, cough, cold, you will get vomiting and diarrhea. In your experience, all those children of influenza that you are seeing, do you also see vomiting and diarrhea and all these things? How commonly you come across these presenting features?
Yes, sir. On careful history taking, I think when we are, like Sir told, we have other viruses also. When we take a history, what strikes to us most is the intensity of the fever. Very high grade fever, headache, body pain. Little older children typically complain of that sore throat, which happens on day 2 or day 3. Severe sore throat, they have a conjunctival congestion, and they may have a little bit of vomiting and diarrhea, which is kind of self limiting. Many a times we do get this history of vomiting and diarrhea as well.
Ah, okay. So that's very important. And of course, there are so many respiratory viruses which we just discussed, the influenza-like illness, H1N1, the severe acute respiratory illness, COVID-19, and many of them have these symptoms in common. And our
Initially they may recover for some time, and
yes,
they show the symptom and they recover, deteriorate fast. Maybe that
yes,
one,
yes.
non-subjective symptom.
Yes, I always make it a point, to call these parents after 3, 4 days
Yes, yes,
again. Yeah, because many times, some of our patients they show biphasic presentation. Like,
yes.
initially they tend to recover, but on day 4 and 5 again, they come up with fever and other symptoms. And these are some of the important presentations which should alert to the emergency warning signs. Like when a child is having a fast breathing, or he has breathing trouble, or he has cyanosis, or he's not drinking enough fluids, or not waking up, or not interacting, or being so irritable that the child does not want to be held. So these are some important symptoms which our listeners must inform the parents that they must come back to the medical facility if they find it this. And the complications of flu, I have just put them in the alphabet A for the benefit of understanding. Like of course the acute respiratory infections, it is known that 25% of patients with flu, they can have streptococcus pneumoniae. Also, as I showed you in the first case, some of them can go into ARDS. Then many of them have acute otitis media. Absenteeism from the school as well as from the offices is also known. And as our colleagues cannot differentiate viral from bacterial, there is a lot of antibiotic abuse. So it is important that we recognize the illness and treat it on time. And the treatment of influenza is classically divided after categorizing the illness into A, B, and C. And there is an antiviral, that is oseltamivir, which we will be discussing now in brief. So it's a neuraminidase inhibitor. Basically, as I told you, that HA and NA, the two glycoproteins which are there, of which this neuraminidase is the one which is responsible for releasing the virions from the infected host cell, and that is the enzyme which is blocked by these neuraminidase inhibitors like oseltamivir and zanamivir. There is another group called adamantanes like adamantidine, amantidine, and rimanantidine, and they interfere with the hydrogen ion channel activity of the influenza A virus. This oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme of the influenza virus A and B. And oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits influenza virus replication and pathogenicity, and it prevents the further spread of infection, and it is effective against all strains of influenza A and B. And this is the diagrammatic representation of the mechanism. In the upper part you can see that the virion and the release of new virions from the respiratory epithelial cell, which continues the viral replication. And in the lower part you will see the role of neuraminidase inhibitor like oseltamivir, which blocks the release of the virions. Okay, this oseltamivir was the first oral neuraminidase inhibitor, and it has been approved in more than 100 countries and also approved by CDC, American Academy of Pediatrics, and major bodies. Dr. Anil, we will just like to know as to what are the current recommendations for the use of oseltamivir in the OPD and the IPD? And what are the different categories of treatment, which I was just referring to, the categories A, B,
Yes.
and C? Like,
So influenza-like illness, when we come to a diagnosis of syndromic diagnosis of what we would call as an influenza-like illness, see, in OPD routine practice, we won't be swabbing everyone. So anybody who comes to us, we syndromically classify them as either a category A, category B, or category C kind of patients. Category A are the routine OPD kind of patients who come to us with a acute febrile respiratory illness. We know that someone else in the family is also affected. They have this fever, cold, cough, body pain, sore throat. And as we all pediatricians, we know uh, viral illnesses are all self-limiting kind of illnesses. By day 5 or at the most by day 7, these are all self-limiting kind of illness. So for category A patients, which are more of our OPD kind of patients, we won't be considering either doing a swab test or a treatment for these kind of OPD kind of patients. So we classify them as category A, give them a symptomatic supportive care, good fever control, educate the parents of all the danger signs like what sir told. Please watch out for any lethargy, poor feeding, persistent vomiting, onset of breathlessness, or any other concern is there. And we should always tell them to come back to us within 48 hours for a review to just make sure that things are all right. And we just prescribe them some paracetamol, oral fluids for the fever, and these can be safely monitored from the home. And category B and category 3 are the, I would say, moderately sick to the severely sick kind of patients will be in category B is moderate, and category C are the sick ones who will require an immediate admission to the hospital and probably intensive care also. So category B and C are the categories of patients who deserve to be treated immediately with the antiviral oseltamivir. So category B, where they're having very high grade fever and they may not be eating too well, or they may develop some respiratory symptoms like a little bit of fast breathing or respiratory effort. These are the patients who will require oseltamivir to be started upfront. And of course, category C, who are sick enough to be in the ICU or needs to be admitted to the hospital, definitely we will go ahead and start them on oseltamivir.
yeah, wonderful. So I will just add that category B includes, you said, those children who are, under the age of 2 years in the pediatric age group. They are put up as high risk, along with those with the chronic health issues like the lung, heart, liver, kidney, blood, diabetes, or neurological disorders, cancer, or HIV or AIDS. So patients on the long-term corticosteroid therapy are also in this category. And many times we have to at least ask the parents whether this child has any particular underlying illness, so that a child coming with fever and cough, if he goes into this high risk category, we can put him on oseltamivir. But now good that you told that category A doesn't need any throat swab, neither oseltamivir, but in category B and C we require both of them, and one has to remember this categorization. And these are the this is the summary of the treatment guidelines. As Dr. Anil told us, category A requires only home isolation, bed rest, plenty of fluids, and paracetamol for fever, while category B, above treatment, there is home isolation, bed rest, etc., plus antivirals, and testing may be done. And category C, testing should be done immediately, particularly these patients are hospital admitted and they can be given antivirals along with supportive therapy. And this is the dosage regimen for oseltamivir, where adults are given 75 milligrams of oseltamivir in the capsule form twice daily. And for the chemoprophylaxis, particularly if there are some high-risk individuals in the family, we need to protect them, like a father who is diabetic, or someone on steroid therapy. But this therapy for prophylaxis is given only once in a day. And in children, depending on the weight bands, the therapy less than 15 kg, 15 to 23, 23 to 40, and above 40, they receive 60 milligrams, 90 milligrams, 120 milligrams, and 150 milligrams, the total daily dose divided into 2 doses, while the chemoprophylaxis dose is only once in a day. And the syrup is also available, which contains 12 milligrams per ml, and the dosages are given accordingly. Particularly for infants between 2 weeks up to 1 year, the dose of oseltamivir is 3 milligram per kg twice daily, and prophylaxis in children under the age of 1 is not applicable. Now, Dr. Somashekar, there is a question as to how does early initiation of oseltamivir influence the clinical outcomes, particularly related to the duration of illness or progression to the severe disease or complications in children, and whether we can start oseltamivir for a child who is admitted with lower respiratory tract infection with distress and who is H1N1 positive, particularly he comes on day 4 or 5 and not within the first 48 hours. So what is your opinion about these two issues?
When you think the symptoms are going from mild to moderate, that is the time you should suspect. Maybe it was the second day or third day is the ideal way. Suppose you have missed because of the differential diagnosis or your, whatever the thinking, strong index of bacterial infection is there or localized infections there. Still, it is worth, if the symptoms are not better, even of the fourth or fifth day, you please start it. But early is the better for the best outcome. On rapid recovery, early is the best. Taken 48 hours to 72 hours.
So even if the child presents late or the parents bring them late, we should
Please,
start oseltamivir.
worth the trying.
Yeah, it is better. Yeah, and whatever you say is amply supported, because in Pune we had a study, and that was of course during this pandemic of 2009, where children who were admitted and came late even on day 8 and 9 also, the mortality was prevented, and that particular paper was published by the institute. So initiation of oseltamivir within first 48 hours reduces the illness duration by 1 or 2 days and decreases the risk of complications like pneumonia, encephalitis, and secondary bacterial infections. And it lowers the hospitalization rates. And the early treatment is associated with better recovery and few long-term sequelae. And if IPD patient studies are there, then they have indicated that oseltamivir can be started as late as 4 to 5 days of illness. It reduces the disease severity and helps to prevent the complications. Okay, so there have been plenty of clinical trials which show the benefits of the empiric and the early use of oseltamivir, particularly in connection with the antibiotic use reduction, reduction in the lower respiratory tract complications, and the percentage of hospitalization, and the reduction in the occurrence and the severity of pneumonia due to H1N1. There have been plenty of studies, and based on those studies, there are guideline recommendations even by WHO, and categorical statement that empiric treatment is strongly recommended. The treatment should be started as soon as possible, and laboratory confirmation of flu is not necessary for initiation of therapy. However, negative laboratory test for H1N1 does not exclude the diagnosis in all patients, and therefore you have to give early therapy. Dr. Anil, at this juncture, I will just like to have your opinion as to, if you send the throat swab for the respiratory viruses and you do not get it positive for H1N1, then what are the chances that even the throat swab being negative for H1N1, the child can have H1N1? That means the throat swab is negative, but still, basically, the child has flu. So, what is your opinion about these tests which are done?
Yes, sir. The latest generation of this PCR studies have got very good specificity and sensitivity. Probably when I looked up at the literature, it told me that the sensitivity and specificity are very high. So sensitivity goes up with a very well conducted test and a good sample. The sensitivity can go up to 90 to 95% also. That means it will detect everyone who has a disease up to the point of 90 to 95%, it will detect. But again, it depends very much on how the sample is collected. If the sample is collected way anterior in the nasopharynx, it may come out to be negative. So what WHO tells us is, considering all these factors, the sensitivity may come up to anywhere between 60 to 90% is what WHO says. So in such a situation where we are clinically, our clinical acumen says this is flu, there is an epidemic of flu going on, and we have started the child on the anti-flu medicines empirically, and we're awaiting the swab. And the swab comes out as negative. But still, the child is clinically, it's an influenza-like illness, most probably like flu, and we don't have any alternative diagnosis. There is nowadays we are doing a multiplex PCR from the swab. We do detect commonly the RSV, adenovirus also along with the flu-like illnesses. Even those viruses are negative. And then probably we need to keep in strong possibility of influenza-like illness, probably H1N1 or H3N2, whichever is going around in our city. And it is worthwhile to continue oseltamivir for a full duration of 5 days in such a situation. But if we find an alternative diagnosis, there is an alternative diagnosis which is existing, like there is a lobar consolidation which comes up. When we start looking at the tonsils or the crypts, we start seeing that there is a follicular tonsillitis which is developing, or the swab picks up an adenovirus or other viruses which can explain such a situation. In such situation, I think carefully we can stop the therapy. Especially the empirical therapy, we may continue if the child is critically sick, his child is immunocompromised. It is worthwhile to continue the treatment even though the swab test comes back as negative.
Yeah, that's good. And these are very, very important inputs from you, Dr. Anil. And an early empiric supportive therapy and monitoring is very important. And we have to give empiric antimicrobials to treat all likely pathogens causing serious acute respiratory infections. And empirical therapy includes neuraminidase inhibitors for the treatment of influenza when there is local circulation or other risk factors, as Dr. Anil just alluded to. So with that, we have one case where this child Viru had fever for 3 days with cold and cough, and he has been on the metered dose inhaler since 4 months. He was well controlled with this MDI, and for this current illness, he receives symptomatic treatment. But he again, after 3 days came back and just he remained afebrile for a day and fever again developed. Otherwise, in between, he was quite active. So, Dr. Somashekar, this is obviously a child where, he has, had again a viral upper respiratory infection. And as I said in the beginning, these have become very frequent and they are occurring at a shorter interval. So, for such parents, who come to you with a presentation like this, how do you counsel them? Because some of them, they come from the IT sector. And I remember, in Bangalore and in Pune, what is common is, of course, these IT sector, information and technology. But these parents are also IT. They are inquisitive and troublesome. Okay, of course, in a jovial way. So just what I'm trying to ask you is rather, these parents are very pushy and they want that Dr. Jog should start antibiotics immediately and the child should not miss the school. So how do you counsel such parents who come to you for a recurrent infection in a short interval?
See, just give some time for them, tell about the epidemicity as well as their clinical picture. They are already experienced that one. They are a frequent episodic user. Whenever you give the MDA, they are better. Maybe new patient will have some dilemma, sit with them and tell. We'll review once again after 3 days. If it persists symptoms or we have some cardinal symptoms related to bacterial infection, then we'll start. And first of all, put a whatever the label in your clinic, don't ask for unnecessary antibiotics. Now that this thing is going on, that you put it, and you always mention about Google doctoring, that also, but convince them about the previous pattern. And this episode, convince them are a new patient. Within 3 days, we'll review and take a call. That is important. And if it is progressing, then we'll start the antibiotic if it requires. That is important. But topic for today concern about this, they are the patient with episodic fever already and they are on MDI. This patient will be definitely benefited with the flu, like vaccination. That helps in the to avoiding the frequent episodes as well as the exacerbation. So we can try with that way. You take the opportunity to tell about the benefit of the vaccination.
Right. Yeah, very important points, Dr. Somashekar. Today, incidentally, is the Rational Antibiotic Day, 26th of September, and some of our colleagues are celebrating it by promoting rational antibiotic therapy. So it is important that you tell the parents that these recurrent viral respiratory infections are seen even 6 to 8 times in a year, and to some, in some children, they could be seen up to 10 to 12 times in a year. So parents need not worry. And I'm sure you will agree with me that if you show them the growth chart, which shows that the child is, increasing in the weight every month and the child is doing well, otherwise his appetite is good, though he is getting recurrent viral infections, he is not suffering as far as his weight and the general health is concerned. So it becomes very easy for us to convince them. So Dr. Anil, do you have any additional points to counsel the parents who are, not very satisfied with the simple paracetamol and cough syrups?
Again, we'll go back to COVID and tell them during COVID, all of us were naive. Whenever we get exposed first time to the viruses, everyone falls sick. Similarly, the child who is just about now entering the daycare school, is going to school, is getting exposed to so many other children, and each child is bringing their own flora from their family, and it's kind of spreading. So each time he comes across a new viruses, he may go down for a couple of days. So this is how the immunity builds. We should tell them that this is how the child is growing. So the immunity is also growing with your child, and we do counsel them. And when it becomes
good point it is.
they really want to get it done, then what we do is, this is the last point, we ask for a swab, even though it may not be indicated, just to buy some time with the parents. So the swab report may take 24 48 hours, and by then probably the symptoms would have subsided, or the swab reports will be reassuring for the parents, so that we'll have some evidence to show that these are the viral infections which are going around.
Yeah, it's very good. And now I will just tell our listeners that it is possible to identify our respiratory infection producing enemies to some extent, particularly when the onset is with cold and sneezing. And when the child is otherwise playful without any exhaustion, it is likely that the virus is rhinovirus, a simple virus producing common cold involving the upper airway. And there could be either mild or no fever. Along with fever, as I said earlier, if there is prominent headache, myalgia, extreme exhaustion, it's likely to be influenza. Adenovirus is a different ball game, which produces pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, hemorrhagic cystitis, and on some occasions we have seen, this virus producing lobar consolidation also. And particularly in children under the age of 1 year, we have RSV producing bronchiolitis. And in COVID times, we have seen fever, dry cough, and loss of the sense of smell and the taste in the older patients. And the bacteria, like the group A beta hemolytic streptococcus, producing fever, follicular tonsillitis, and tender cervical nodes, and pneumococci producing fever, along with grunting and tachypnea, and staphylococcus producing rapidly progressive illness and a toxic child, and mycoplasma producing particularly, cough in little relatively older children. So with this, Dr. Anil, there is a child, a 4-year-old child with cough and fever of high grade for 5 days, and he is not settling with oral medicines. And on admission, he has tachypnea and needs oxygen support. And this is the X-ray which was taken up, and the hemoglobin was 11.6, and the total count was 1620 with platelets of 132,000, and SGPT and SGOT were on the higher side, and the nasopharyngeal swab showed H3N2. So this was a case of influenza with low WBC count and low platelet count. Now, given this particular case, do you have any important points to make related to the presentation and the laboratory investigations
Yes.
in this child?
So this one straight away is our influenza-like illness in category C. This child is quite sick, tachypnic, requiring oxygen, and quite a significant low respiratory involvement has already started. So this is straight away category C, who needs to be admitted. Probably if the respiratory distress is more, probably even in the HDU or an ICU kind of a setting also. And appropriate cultures needs to be taken. And this child, definitely, since being in category C, will be deserving Oseltamivir, even empirically, even before the swab results are out. And also, we always take help of the other lab results. So typically, we do see this leukopenia, 1,600 of total counts, and the platelets also being on the lower side. Slight elevation of the transaminitis, which is telling that it's a multi-system involvement is started. So definitely, this is a candidate who requires Oseltamivir and will definitely be benefited by it. And of course, whenever this kind of a thing happens, till our cultures are back, such a sick child, we will be starting the child on an antibiotic also, pending the blood culture results.
Yeah, that's a very good point. Now, I had just one or two quick questions. Now, suppose this child is admitted in the maybe in the intensive care unit or somewhere, and the throat swab report is not yet available. In view of this low WBC count and the low platelet count, what are the chances that this is likely to be a case of dengue fever, as per your opinion? Because the liver functions are also damaged to rather deranged to some extent. What will be your lookout as far as co-infection with dengue in these cases?
Yes, sir. Endemicity also plays a key role over here. Whenever there is a surge of dengue epidemic that's going on, it is definitely worthwhile to rule out dengue fever in such a patients.
Yeah, I agree with that, because why I asked you this is, because I remember right from my days of residency, everybody says that dengue fever means no cough, cold fever. Okay, if you get a child with cough, cold, and fever, never think of dengue. So, do you agree with this statement? And presently,
No,
uh,
we had both picture.
uh,
We had some few packets of viral hemorrhagic fever, and both were positive. We had.
okay,
The only
okay,
thing is we serially monitored platelet and the
uh,
hemodynamic status and closely
correct.
monitored.
Yeah, yeah,
Coexist, co-infection is a
So,
possibility, sir. We
yeah.
can't rule it out. Co-infection is definitely a possibility whenever in the endemic areas and there is a huge outbreak like this. We should always keep our antennas up and we should screen for dengue and possibility of influenza-like illness. Definitely, we need to keep in mind.
right, right. So that's a very good point in this discussion. There is a question, Dr. Somashekar, as to whether oseltamivir be started empirically or only after investigation. This is only to reiterate the facts which we already discussed. So you can just tell your opinion.
So given the table chart which you have
Yeah,
mentioned clearly. The
yeah,
thing is first after the investigation, it is for the high index of suspicion where category B or category C admitted, wait for first, do the swab test. Meantime, if you have got strong suspicion, progressive symptoms, start it. Otherwise, there is no point in starting because there is a component, keep always a component resistance. That another thing is empirically word comes in a patient with high risk patient with lot of comorbid condition like an nephrotic syndrome. Be careful. Patient with progressive neurological disorder or immunocompromised state or any chronic lung diseases or uncontrolled wheeze or asthma. Please take care. There you can start if symptoms are progressive. Otherwise, better in IPD patients, if you have a strong suspicion, do the swab, then you start it.
that's very good. And of course, for the benefit of our colleagues who are, staying in places where facilities for the throat swab are not there, then that categorization into A, B, and C is of great help, isn't it? Yeah. This was another child, 3-year-old with cough and fever for 3 days, and fever was not settling. The counts were normal, and the nasopharyngeal aspirate swab that showed S3 and 2. And another child, same one. I'm just trying to show the different children who came for S3 and 2. Here the counts were normal, but the CRP was 38 and the swab showed S3 and 2. Dr. Anil, what are the factors on which the clinical response to oseltamivir depend? That means you have started oseltamivir. So what are the factors on which the response to this antiviral would depend?
So the most important factor is how early did we start it? Because we saw that it is a neuraminidase inhibitor. So this kind of prevents the spread of virus from one cell to the other cell. It kind of ruptures and the host cells are infected in multiples. Each cell it is entering, more number of virions are being released. So by starting it early, what we are doing is we are limiting the spread and the complications. So the literature tells us that within 48 hours, if it is started, it has got the best response. And even though in sicker children, where they are moderate to severely sick, even though they are presenting on day 4, day 5, and a progressive illness, I think we should not wait. Even though it is day 4, day 5, we should go ahead and start. So the literature tells us that starting oseltamivir early will bring down the response, or the clinical recovery period time is shortened by almost 2 to 3 days of shortening is there of clinical recovery time. I think we should extend this benefit and think about this influenza-like illness and start oseltamivir pretty early in the illness whenever the clinical suspicion is high. And for the sicker children, do not deprive them of this benefit. Even though it is day 4, day 5, to prevent the progression of illness, we need to start it even if it is day 4 or day 5.
Wonderful. So this is another child which was a little bit tricky because this child came with cough, cold for 5 days with high WBC count, high CRP of 136, had continuous high fever, but the swab proved to be positive for adenovirus. And this is what Dr. Anil referred to earlier, that sometimes you can get these viruses and the clinical presentation is quite overlapping. That's why many times I say that all those viruses, rhino and RSV and adeno, influenza, parainfluenza, to
Adeno
clinic.
mimics like sometime bacteria also.
Yeah, I agree.
ERP and other things.
Correct,
Like
yeah.
this.
So I always say that even Rajnikant cannot differentiate, clinically which is the virus, isn't it? So anyway, now this is another girl, 5-year-old, with high fever for 5 days, with cough and cold for 5 days, sick looking, with mild wheeze, but no crepitations. Now, Dr. Anil, will you put this particular girl on antibiotic therapy?
So this is a 5-year-old child. Already we are into day 5 of illness, and
Sick.
child is looking sick.
Yeah.
So with no crepitations and a mild wheeze, probably this is kind of fitting into influenza-like illness. If it was to be a mild one, it would be a self-resolving illness by day 5 of illness. But since the child is already into day 5, if it was a purely viral kind of illness, probably the clinical improvement would have started by now, day 4,
Yeah.
day 5. Since already she's into day 5 and looking sick, yes,
Yeah.
I'll go ahead and start her on a antibiotic also till I get further answers.
Yeah. So now she was put on amoxiclav. The counts were 2800 total count with neutrophils 10, lymphocytes 70, CRP of 34.7. And she was put on oseltamivir, but the nasopharyngeal swab showed rhinovirus. Okay. So actually, this particular question related to the sensitivity of this influenza PCR and the treatment decisions you have already alluded to. But then I just a follow-up of that question is, if you get some viruses like rhinovirus in this throat swab, how would you look at that particular report?
Rhinovirus, it's usually a self-limited virus. Like I told, by day 5, things would have been already getting better. Rhinovirus, we do see in small infants. It's more of a localized infection, more of runny nose, blocked nose, or at the most like a bronchiolitis kind of an infection. But for an older child, rhinovirus being there, probably it is just there as a commensal, or it's a coexisting kind of a thing. And the CRPs are slightly on the elevated side. So in such a situation, I think I wouldn't give much weightage to this rhinovirus being positive. I don't think so. Rhinovirus, it's a localized virus. It doesn't cause too much of a systemic illness. So rhinovirus, I would take it with a pinch of salt.
Okay. And are there any other viruses like rhinovirus where you would not give much of importance to these viruses in the report? Like any others? Like how about this RSV? How about then parainfluenza, adeno? Then So are there any viruses which are like innocent bystanders? We say they are just there. Is there any other virus like this? RSV, if you get it in the throat swab, you will take it as a pathogen or you will take it as innocent one. Uh,
Probably RSV is usually bronchiolitis kind of a presentation, especially in
yeah,
small babies.
yeah,
If
yeah.
clinically it is not correlating, probably we'll just take it as a commensal.
Okay. So in association with the associated symptoms, isn't it? Yeah, right. Anyway, so Dr. Somashekar, this is a 7-year daughter of an IT sector parent, which we said earlier, came for high fever for 3 days and with throat irritation, and she has exam after 2 days, and the throat is showing mild congestion, and paracetamol has been given, but the flu and the adenoviruses are in the atmosphere. Okay, so the question is as to how to go ahead because the parents are after you to put on something or the other. So you do the CBC, CRP, you do the throat swab, and you put the girl on empiric Oseltamivir. So how would you go about in such cases? Those where the parents are very pushy and they want that something should be done. So what all will you do out of this?
She's 7 years, she's not sick and mild congestion. Only the stress is exam. You can do CBC, CRP, you can do the empirical, whatever the swab. But I am skeptical about starting this on the Oseltamivir. Okay. And just tell them because it's a mild nose, she's not sick, she's not progressive. Maybe exam is there. Reassure them, look for the other other bacterial infection surrounding your examination, periodic examination is better rather than giving a oseltamivir.
Okay. So
And
you
if
want,
the swab comes positive, then you start.
okay. But then would you subject this girl for a throat swab, knowing the categorization of flu into A, B, and C? Where do you think does she fit in this? Because here, high fever is one of the pointers to type the other category B, but
Yeah.
then other indicators are not here. But then maybe, as you say, we can investigate this girl because the parents are from IT sector and they want that something should be done. But then, of course, you can decide the further plan of action depending on the report of the throat swab. But
Within
then,
12
yeah,
hours, we'll get the report nowadays.
pardon? Oh, is it so?
Within 12 hours, we'll get the reports.
Acha, you get it very
Reports.
fast, huh? Okay,
Yes.
okay. Yeah, that's great. And then generally, as I would like to ask you as to how long should oseltamivir be administered? Why I'm asking you because I have seen some adult physicians, they continue to give oseltamivir even for 10 days. Have you come across such a practice in the adult physicians anytime? Maybe Dr. Somashekar or Dr. Anil, for those who are admitted in the hospital, particularly for patients who are very sick, they give even the dose of 150 mg also. So have you come across this practice anytime?
Yes, sir. Adult physicians do practice this, but
Mhm.
wherever the literature says if it is for treatment, 5 days of treatment
5
is
days.
good enough.
Right.
For prophylaxis, sometimes up to 7 days can be given. But whereas for treatment, 5 days is good enough, is all the literature that says.
Yeah, yeah. So at least as
This 10
pediatricians.
days business, previously we used to come across more with the awareness.
Hmm.
That
Yeah, yeah,
post-COVID,
yeah.
out of the regular webinars,
Yeah.
has made little change.
Yeah, yeah, you're right. And this is another boy who is 3 year old with cough for a week and high fever for 3 days with crepitations. And he was put on coamoxiclav by our colleague, and he was admitted for persistence of fever. And then he was put on IV augmentin, and WBC count was 7700, CRP was 2.8. The swab showed influenza A, and depending on the swab, he was put on oseltamivir. So now, Dr. Anil, the question is now already the swab has come positive, but the child is already on amoxiclav. So will you like to stop the antibiotic or will you like to continue the antibiotic in such cases?
Sir, with all confidence, I'll go ahead and stop augmentin in this case because this child is having little crepitations. Clinically, the picture is of influenza-like illness. The swab is also supporting our suspicion of influenza-like illness, and the
Right.
labs are also supportive in this case. I think if clinically the child is getting better after 48 hours, by the time we get the swab clinic, child is already getting better. I think we can go ahead and stop the antibiotic which is going on.
Right, right, right. I fully agree with you. Maybe even if you have prescribed antibiotics concurrently in the beginning, depending on the report, you can always discontinue. And at least today on this antibiotic stewardship day, we must opine that if PCR is positive, one should not continue with these antibiotics, provided all the other situation like the laboratory reports and all are favoring influenza. So, to conclude this discussion, we have a rapid fire round wherein some questions I will be asking. So, Dr. Somashekar, some of these we have already answered partly, but just to repeat, if a child gets admitted on day 4 of the illness for LRTI and comes influenza A positive, shall we start oseltamivir, and up to what
Yes.
day of illness it will be effective?
Even 4th day or 5th day, as we mentioned, the LRT is there. Category C, it is better to start.
Correct. Dr. Anil, the elder sibling of an 8-month-old child is admitted with influenza A for LRTI. And this 8-month-old child, the younger brother, develops fever since last evening. So whether we should start oseltamivir for this younger one?
Yes, sir. In infants also up to the age of 14 days and above, the oseltamivir is licensed for use, especially with this elder sibling having a proven case of influenza A. this child deserves to be treated with Oseltamivir. 3 mg per kg is the dosage. In twice a day, daily dosage can be started for 5 days.
Right, right. Very good. And particularly, as we said in the category, that all those who are under the age of 2 years,
2
they
years
fall
are
in
at high
the
risk.
yeah, they are in the high risk group. So more the reason for putting this child on the on Oseltamivir. Then Dr. Somashekar, uh, what if the child is not accepting oral Oseltamivir? Is there any alternative?
For all the medications, even the parents say that. But in the IPD sector, it's a different story. You can get patient is gives try RT tubes and other things. But here GA symptoms are there. Small dose. You can repeat every 2 minutes or 3 minutes. Complete the dose can be done. Or if it is antiemetics can be added. But usually they are tolerable. We should give. If you have got
Okay,
IPD symptom suspicion, better to give it.
okay. And
But
then
no alternative. No alternative.
yeah, there is no alternative. This is, and it's only oral. There is no IV also. Yeah. Dr. Anil, if there are some household contacts in this family, like the grandfather, the grandmother, etc., then whether we should give chemoprophylaxis to all those contacts where the child has come H1N1 positive or H3N2 positive?
If someone in the household is rated positive, we should be very careful when we are using a prophylaxis. A healthy adult parent who doesn't have any comorbidities may not deserve to be started on a prophylaxis, whereas someone who is aging 60 and 65 years and above, or is having any other chronic conditions like a heart condition, they're asthmatic, they have a lung condition, they're immunosuppressed, someone is going chemotherapy, anybody who falls into that high risk zone should definitely be started on a chemoprophylaxis. As Sir has been mentioning, children under the age of 2 years also will come as high risk zones, but usually children less than 3 months, we don't start them on any chemoprophylaxis. If they're sick, yes, of course, babies as young as 2 weeks can be started. Some studies say that even less than 2 weeks old NICU babies who are extremely sick, they can be treated on case-to-case basis. But when we are doing a chemoprophylaxis, we should be careful that healthy adult contacts may not deserve to be started on chemoprophylaxis.
Right. Yeah, that's very good. So that, our listeners should remember that if there is someone on a prolonged steroid therapy or someone where angioplasty has been done in the grandfather and a grandson is now down with H3N2, it is better that you give chemoprophylaxis. And then Dr. Somashekar, currently, children are coming with high-grade fever, severe sore throat with cough and cold. So whether we should start Oseltamivir to all those children coming to us with this, particular symptom complex?
We got a lot of infection mimicking the same, both viral, bacterial, everything. So there is no upfront starting. There is no point in starting this, especially this very good drug of oseltamivir. Keep it preserved because we are worried about the resistance later. So high takes a suspicion. Think of then do the test and do that whatever the needful. Otherwise, upfront as a prophylaxis, don't start.
Yeah, I agree with you. And only that high-grade fever is one of the features of the category 2. And one can have a look at the situation of this
Yeah.
particular clinical condition and then take a decision, particularly in such a child. And then, Dr. Anil, just a last question for you as to, if there is para-influenza virus which has been detected on the respiratory panel, does oseltamivir work on parainfluenza?
No, sir. Parainfluenza viruses, these are the viruses which come out as croup in the small babies. Usually, we suspect parainfluenza whenever we are seeing a croupy kind of a baby. And usually, even though the swab is detected, oseltamivir doesn't work and not indicated in such patients.
Wonderful. So we have now a lot of clear-cut information about influenza and influenza-like illnesses. So along with therapy, it is important that you follow the cough etiquette, then the Hasta Pancha Sutri. These are the 5 rules related to the hand hygiene, particularly washing the hands after examining every child and avoiding the handshake as far as possible, using the handkerchief and keeping the other persons at a hand's distance, and avoiding hand touching. And as medical fraternity, it is very important that we ourselves do not spread this infection to others, because we are the ones who are maximally exposed to such patients. So with that, I say namaste, and not a handshake but a namaste to all our listeners. And I thank Dr. Anil and Dr. Somashekar for giving crisp answers, and thank Hetero for allowing us to expose our knowledge for the medical education on the day of rational antibiotic therapy. Thank you.
Thank you, sir.
Thank
Thank
you
you,
so
sir.
much.
Thank you, sir. Thank you. Very good
Thank you.
moderation.
Thank you.
Thank you.
Great.
As usual, sir, it was a very lovely and lively session. Thank you so much.
Thank you.
Thanks,
Thank
Dr.
you.
Somashekar. Thanks, Dr.
Thank
Anil.
you.
It was a
Thank you.
beautiful interaction. I'm sure the audience has benefited. So these
Thank you,
interactions will
Pramod
give them
sir.
confidence. Thank you.
Thank you, Anil dear. Nice
Thank
of
you.
you.
Thank you, sir.
Thank
Thank you
you.
so much.
Thank you.
So we'll
And
meet. We'll meet tomorrow again.
yes.
Yes, sir.
Yeah.
Thanks,
Okay.
Amrude. Thanks, Nagadevi.
Thank you, sir.
And thanks all
Thank
the
you, sir.
audience who took time and attended
Bye.
this.
Thank you.
Thank you.